Sir, we can start.
Okay, thank you. So today we have another hepatology session. I think this session will be very, very interesting as this is a really very interesting case and a different type of management. And I would like to thank Professor Azam, come forward and he mentioned to me that he did publish this case report in the journal, and would like to share his experience on this case. So today's talk, the topic would be a case-based approach, use of extracorporeal therapy in acute liver failure. Acute liver failure is really, really a life-threatening condition, and usually defined as acute liver injury within a short period of time with someone no pre-existing liver disease and accompanied by coagulopathy and hepatic encephalopathy. So the management is very limited, especially from Bangladesh perspective, like in here in USA and other countries where liver transplant is really available, and it's the only therapy that can improve survival. But we have to do something for our patients in Bangladesh. Hopefully in the future, when liver transplant will be a standard of care for a lot of our patients, then something we can implement this. But until then, something we need to do about those patients who are really sick, very high mortality, and some center are doing certain things that kind of more like a bridge to recovery, more to say. And we will hear this case from Bardem. Dr. Azam, Professor Azam, he was involved in this case, so we're going to hear from him. So today we don't have presenter would be Dr. Muhammad Ashik Maula. He is a gastroenterology Phase B resident from Bardem General Hospital. We have several panelists. The first one is Dr. Atiquuzzaman Atiq Bhai. We all know him very well. He's the chairman of PHA, and he's a Faculty College of Medicine, University of Central Florida. He's also a director of Digestive and Liver Center, Florida. Atiq Bhai has been really, really instrumental in, kind of promoting a lot of things, through the PHA, especially from me personally, helping me and with the liver transplant program, we're trying to kind of establish and help establish liver transplant program in different hospitals. So, and then we have Professor Ghulam Azam. He's just promoted to professor. Congratulations. Also head of the Department of Gastroenterology and Hepatology. He's a liver transplant coordinator at Bardem General Hospital. I think he is trying to also establish a liver transplant program in Bardem along with BMU. Unfortunately, Professor Farooq Ahmed, I really admire Professor Farooq. He's been so academic and he really, really wanted to join, but unfortunately, something came up. He has to attend some family gathering, so he would not be able to join today. Then we have two nephrologists because the care involved a treatment which really need expertise from nephrology. The first one we have Dr. Mahfuzur Rahman, Amar Choto Bhai, from the same medical college. He's a chief of nephrology at Sutter Medical Center in Sacramento, California. And then my another Choto Bhai, Dr. Ihsanul Karim from the Salimullah Medical College, and he is associate professor and Department of Nephrology, National Institute of Kidney Disease and Neurology. So welcome you all, and without any further ado, Dr. Maula, you can start your case, and then after the case, we finish the case, we can do our discussion. We can hear from our panelists.
Assalamu alaikum, sir. Respected moderator and panelist and audience, I welcome you all. Assalamu alaikum. I welcome you all. I am Dr. Muhammad Ashik Molla, MD resident, Phase B Gastroenterology. On behalf of GSPD department, I am going to the case. Sir, how can I share my slide?
So if you go to your computer, you just see share. Are you in the computer? You are using PC, right? The laptop. Please.
Yes, sir.
Yeah,
You
can
share
I
up.
go to the green one? Like there is at the bottom of the screen, there is something called share screen. Click in there.
Yes, sir.
There you
Yeah,
go.
you're right there.
And then you can. There's a button here at the bottom. You see slideshow.
Yeah, just put it in the slideshow.
Sir, can share my screen, sir?
We all can see your screen. We just have to put it in a slideshow mode. So in the bottom, you see. I think it's in the.
So can you see my screen, sir?
Yes, we can see your screen.
So can I start my lecture, sir?
Yes, you can. Go ahead.
Okay, sir. Assalamu alaikum. I am Dr. Mohammad Ashik Molla, MD resident PhD gastroenterology. On behalf of GSPD Department Bardem, now I am going to present a case. The title of my case is the hemoadsorption with cytosorb in a patient of sepsis, AKI, and acute fulminant hepatitis. This is the case report of 48 years old woman with diabetes mellitus, hypertension, polycystic ovarian syndrome, who was transferred from a peripheral hospital to Bardem with sepsis, AKI, and deep jaundice.
Dr. Mala, sorry to interrupt.
Yes, sir. Yes,
Can
sir.
you change your slide because it's so. Yeah, there you go.
Now, okay, sir.
Yes,
Can I proceed, sir?
yes, you can.
মিউজিক শুনতে পাচ্ছি দেশি গানের মিউজিক শুনতে পাচ্ছি কেন মিউজিকটা বন্ধ করে কোথায় মিউজিক হচ্ছে ওকে স্যার She admitted in a peripheral hospital on 4th January 2024 with history of fever, yellowish discoloration of skin. Fever, yellowish discoloration of skin, sclera, and urine associated with intense itching for 7 days. Had a history of taking NSAIDs, herbal medication for her illness. She gradually developed a reduced urine output. She had leukocytosis 44.8 thousand per microliter with high ESR 41 millimeter in first hour, hyperbilirubinemia 15.2 milligram per deciliter, and had altered liver enzymes. Her SGPT was 450 unit per liter and alkaline phosphatase was 902 unit per liter. Intravenous antibiotic ceftriaxone was started. Gradually, her serum creatinine raised to 7.1 milligram per deciliter, and she got her first hemodialysis on 6th January. Due to complexity of clinical picture, she was referred to advanced center and was admitted in Bardem on 8th January. The management at Bardem, the patient was conscious, oriented, breathing spontaneously despite getting oxygen inhalation via nasal cannula, but she was slightly somnolent. On auscultation of the chest, she had bilateral crepitation. After some time, the patient developed respiratory distress and therefore shifted to the ICU. Her serum bilirubin raised to 24.1 milligram per deciliter. Procalcitonin was 23.2 microgram per liter. Serum creatinine was 9.7 milligram per deciliter. Ferritin was 2,268 nanogram per ml, and serum potassium was 6.3 milliequivalent per liter. Her chest X-ray showed bilateral pulmonary edema. All serological markers for hepatitis were negative. Along with standard of care, on 9th January, she got her second hemodialysis in association with cytosorb. She got third hemodialysis along with cytosorb after 24 hours of the first one. 2 sessions of cytosorb was completed over a period of 48 hours duration. Each session consists of 12 hours with 24-hour pause interval between sessions. Cytosorb was used in combination with renal replacement therapy by dialogue of B. Brown Medical Inc. Blood flow rate 150 ml per minute, dialysate flow 2000 ml per minute, anticoagulation none, cytosorb absorber position pre-hemofilter. Antibiotic therapy with meropenem and moxifloxacin were started. Clinical findings. before pre-cytosol therapy and post-cytosol therapy, there is significant improvement. Like temperature before one is 100 and post-cytosol therapy is 98 degree Fahrenheit. Heart rate 102 degree 2 beat per minute before cytosol therapy, and post-cytosol therapy there was 92 beats per minute. Respiratory rate 20 breaths per minute before cytosol therapy and 14 after cytosol therapy. Urine output, that is 50 ml per day pre-cytosol therapy, but after post-cytosol therapy that increased in 300 600 ml per day. Systolic blood pressure 150 millimeter mercury before cytosol therapy and 130 millimeter mercury in post-cytosol therapy. Diastolic blood pressure is 80 millimeter of mercury pre-cytosol, and post-cytosol that is 70 millimeter of mercury. Mean arterial pressure is 103 millimeter of mercury in pre-cytosol therapy and 90 millimeter of mercury in post-cytosol therapy. And X-ray findings, that is the edema is present in the pre-cytosol therapy that was subsided after post-cytosol therapy. After 2 cytosol sessions, serum bilirubin significantly decreased from 24.1 milligram per deciliter to 5.6 milligram per deciliter. Liver enzymes also decreased. SGPT decreased from 335 unit per liter to 59 unit per liter. And SGOT decreased from 183 unit per liter to 92 unit per liter. Procalcitonin also decreased from 23.2 microgram per liter to 9.54 microgram per liter. The patient was breathing spontaneously and was oriented. After 5 days of ICU stay, she was transferred to the normal ward. The patient was discharged back to the home 26th January after 13 days of complication-free course. Laboratory findings: pre-cytosol therapy, post-cytosol therapy, and 7-day follow-up therapy. Hemoglobin was significantly improved. Pre-cytosol therapy, that was 11.4 gram per deciliter. Post-cytosol therapy, that is 9.3 gram per deciliter. And 7-day follow-up, that is 10.1 milligram per deciliter. And in the slide, we show the significant improvement into the bilirubin. That was for 24.1 milligram per deciliter in pre-cytosol therapy, and post-cytosol therapy that was 10.8 milligram per deciliter. And 7-day follow-up, it decreased to the 5.6 milligram per deciliter. And there is also significant improvement of the liver enzymes like SGOT and SGPT and CRP. In procalcitonin, that was pre-cytosol therapy in 23.2, and in post-cytosol therapy, procalcitonin level was 9.54. This is the article show the hemoadsorption in the liver indication analysis of 109 patients data from Cytosol International Registry. This article show the most profound changes from T1 to T2, that is -4, was observed in the serum bilirubin level. According to very recent in vitro study comparing the MARS to cytosol hemoadsorption therapy, the latter removes more necrosis factor, tumor necrosis factor alpha, interleukin 6, ammonia, as well as albumin-bound toxins such as indirect bilirubin and bile acids more effectively than MARS therapy. This is the another articles show successful elimination of bilirubin in critically ill patients with acute liver dysfunction using a cytokine absorber and aluminum dialysis. This is the pilot study. Here show the 39 patients with acute liver dysfunction and correspondingly high bilirubin levels, that is more than 10 milligram per deciliter. 33 patients treated with the cytosorb and 6 treated with the advanced organ system support. Significant increase in the total bilirubin in the period prior to the cytosorb, that significantly decrease in bilirubin during the cytosorb treatment. Significant decrease in the AST, ALT, and gamma GT observed during the cytosorb treatment may reflect improvement in the liver function. The easy use of cytosorb therapy could be the advantage over the other procedures. Here this picture diagram show the cytosorb therapy in the continuous renal replacement therapy in pre-dialyzer. This is the another article show the hemoadsorption by cytosorb in patient with the acute liver failure. These articles show the significant increase in the decrease the bilirubin level from the pre-treatment in post-treatment value. Use of cytosorb was associated with the decrease in the serum bilirubin ammonia levels. The use of cytosorb was associated with an improvement in the liver function test and a decrease in the C-reactive protein. Cytosorb can be considered as a therapeutic option for the management of the liver impairment in patients with the acute liver failure. The cytosorb absorber. It is made of polystyrene divinyl benzene polymer. It is coated with the polyvinyl pyrrolidone. It is a biocompatible porous polymer beads that removes the various substances from the whole blood via the absorption. Relevant surface of absorption located inside the beads. In the right side of the slide, show the absorption criteria. There are three criteria factors for absorption. That is hydrophobic attraction to the surface, and also size selection for the molecules, that is less than 60 kilodalton, and the concentration dependent. Important features here is the absorption surface of approximately 45,000 meters square, and size selective absorption of the hydrophobic substances up to around 60 kilodalton. That is substance that have to small enough to enter the bead and hydrophobic to develop absorption interaction. And concentration dependent removal, high removal efficiency only in the elevated concentration. These criteria are used in this cytosorb therapy. Cytosorb therapy fields of indication, that is removal of the cytokines to regain the control in the septic shock, and COVID-19, and bilirubin levels, bile acid, ammonia in liver failure, myoglobin in case of rhabdomyolysis, cytokines in case of cardiac surgery, intra or post-operative, and ticagrelor or rivaroxaban in case of emergency cardiac surgery. Cytosorb advantage in the acute liver failure, they show the auto-intoxication by the bile acid, bilirubin, and the ammonia, and also the immune dysfunction by the pathogen-associated molecular patterns and damage-associated molecular patterns and cytokines. Here the liver toxin removal plus immunomodulation by the cytokines. Now the patient selection in the liver dysfunction, when the patient's serum bilirubin level is more than 10 milligram per deciliter, and hepatic encephalopathy grade equal or more than grade 2 level, acute liver failure or acute and chronic liver failure grade 2 or 3, concomitant vasoplastic shock not responding to the standard therapy, it is best to be used within the first 24 hours, and onset of liver failure after the surgery or the transplantation, and intractable pruritus. This diagram shows the ongoing liver dysfunction without irreversible organ damage. Then the patient criteria to decide on the cytosorb therapy: if the bilirubin more than 10 gram per deciliter, hepatic encephalopathy equal or more than grade 2, refractory septic shock, and the sign of the hyperinflammatory responses like the procalcitonin more than 3 picogram per liter and CRP more than 100 milligram per deciliter. Then cytosorb therapy can be integrated in the hemoperfusion, continuous renal replacement therapy, and extracorporeal membrane oxygenation. Then begin the cytosorb therapy for 3 sessions with 8 hours interval. If the patient can improve, then we can stop. If significant sign of sufficient clinical stabilization, like bilirubin less than 8 milligram per deciliter, significant improvement in the hepatic encephalopathy, shock removal, or the control of the hyperinflammation, then we can stop the cytosorb therapy. But if not significant improvement, then we can add the newer absorber. And after the 12 to 24 hours to assess the significant clinical improvement. Now the integration on different platforms, cytosorb can be integrated into the existing cardiopulmonary bypass machine, renal replacement circuit, and extracorporeal membrane oxygenation system, and hemoperfusion machines already in use in the hospitals. This slide shows the different device. There is anticoagulation for cytosorb therapy. It normally is as usual. Now the conclusion. In this patient with the sepsis, AKI, and acute pulmonary hepatitis, the combined treatment with the standard therapy, renal replacement therapy, and the cytosorb resulted in the rapid reduction of the bilirubin plasma concentration and stabilization of the inflammatory markers. Cytosorb was preferred due to its ease of use combined with the high efficiency and proven safety profile. Cytosorb was safe and easy to use in combination with the renal replacement therapy. So thank you for all for patient sharing.
Thank you, Dr. Maula. This is a great presentation, really a very interesting case. seems like a magic in ELF patient, and they're pretty sick. I have a couple of questions, and then we would like to hear from our nephrology colleague first, kind of more like simplified way to understand these extracorporeal devices and how it works. I know you explained very nicely, comprehensively. So for us, a lot of the other trainees kind of understand how it works, number one. And then I would like to hear from Professor Azam as well. I know this is a published case report. If he has any other patients had experience with this therapy. So the first few questions I have is, so acute liver failure, right? So the two most important thing we monitor is INR ammonia. And what I understand, because that's something I don't know if I missed it, if the ammonia was checked, because this one important thing to monitor with the acute liver failure patient, and this is the most common cause of mortality, is intracranial hypertension. Since we don't do invasive monitoring, one way to assess to check the arterial ammonia, if possible, if not, then we check ammonia. If more than 150, we kind of know that there's a patient high risk for intracranial hypertension, cerebral edema. That's when you kind of start CRT and all that, right? And then the other thing is, since it's cytosorb, there are a lot of other extracorporeal device which we'll hear from nephrologist. This is in addition to, because if you think about other Mars or it's called albumin dialysis, and we have plasma exchange, other bioartificial devices. One of the advantage of the cytosorb is it, in addition to the detoxify all the toxin like albumin-bound toxin or water-soluble toxin, it also reduce the inflammatory marker, right? So like a cytokine. So have you guys checked the cytokine on that patient? So INR ammonia, what was the INR ammonia level and the cytokine level? We're able to check the cytokines like IL-6.
May I respond?
Sure, absolutely.
Okay. Thank you for giving us the opportunity to present a case. Actually, it has been published, but because of a success story, I like to share in this PHA format. And I must thank to the PHA chairman and you also. Thank you. So it was actually a complicated case. Came to us from Rajshahi city area. Eventually, the patient got the first dialysis, but when her clinical condition deteriorated, and I should not disclose the actual identity of the patient, but she was an university level teacher. And they are a much educated family, and they have the capability to take any sort of treatment cost. So she came to Dhaka and we took that charge. Actually, the patient landed to Bardem in the Department of Nephrology because of a high creatinine level. And the nephrologist consultant have a consultation referral to me because of the raised bilirubin. And finally, the nephrology of Bardem and a dialysis unit, our GSP gastroenterology department, hepatology department, and intensive care department, both of us work together to manage the case. We have missed the parameters. You have mentioned that INR, ammonia, and IL-6. So actually, IL-6 is not done routinely, so we missed that parameter. And about INR, the highest INR was 16.9, not mentioned in the slide, but I missed it, and we have the record. I have recalled it and collected that. The preserved data is already preserved in my hand. So it was the highest INR was 16.9, and it comes normalized up to 12 or 13 like seconds. And ammonia level is somehow missed, but I think.
Is it INR or is it?
Sir, yes, please.
Or INR?
INR was a maximum 16.9.
It's pretty high.
16.9, our control is 12. So it's 5 seconds higher than the control.
It's a PT then, right? Not INR.
PT.
No, sorry, it's seconds. 16.9 second, not INR.
No, but it's a PT then. If it's a control is 12, then it's probably PT, not the INR.
Actually, Prothrombin time in second was 16.9 highest, and the subsequent results was 13.0 second. Sorry, it's
Okay.
not INR, but it's second.
Yeah.
So it was so high, and it comes down to normal. And ammonia level was also missed here, and I cannot, ammonia we do, but I can't have the value in my hand. But IL-6 is not done routinely in our setup. So this is an explanation, sir. Thank you.
Thank you. Yeah, I mean, this is, like I mentioned at the very beginning, since, in Bangladesh, a liver transplant is not available, we got to do something, something different, at least, although data are, and the nephrologist will kind of discuss the data are limited, but although there is no randomized control trial on any of the extracorporeal device, but at least something can be done, to patients like this, at least improve or, even, improve survival. So that's really, really important. And I think you guys did a good job with this therapy. So I'm gonna go to first start with Mahfouz, kind of give us a little bit idea about different extracorporeal therapy, simple way, so that because we are not nephrologists, so we can understand a little bit better how does it work, as far as and then I'll go to Ehsan, Dr. Ehsan.
Yeah, thank you, Dr. Malik. It's an absolute pleasure to be joining a session where very distinguished panelists are present, and it's an learning experience for me, at least, being with the hepatologist and get to know the hepatological emergency or the critical care patients and how to bridge with the nephrologist. As a nephrology, we always work with the ICU team and the hepatologist as well. So I first want to thank Dr. Maula, who actually presented an excellent case. And the way he presented is very precise, very, very enlightening. So he actually discussed about the hemoadsorption as a therapy very precisely and very nicely. So just to be giving a little bit of highlights on what we do, our job as a nephrologist, when a patient's go into the absolute renal failure, there are certain tools that we have to help the patient. And the number one, or the mostly what we used, is the hemodialysis. And it's been in the service for ages, of course, by now, and we all know that. So basically, it's a membrane. It's used multiple different things like the diffusions, convections, and those are the physiological basis of a filter there where we circulates the blood from one end, from the venous blood, and then just other end, we just clear the toxins. And the toxins, what we meant here is the uremic toxins. And the uremic toxins in our understanding, those are actually all lower molecular weight toxins. And when we say the lower molecular weight toxins, the particular measurements that we do is the urea. And that is the easiest way to do it. And that's why, throughout so many years, the urea clearance is the benchmark for looking into the efficacy of the hemodialysis. However, there is a caveat of doing that, and we, as a nephrologist, acknowledge that fact that it's not all about the uremic toxins that make things worse for a patient, and especially for the patients who has different other problems, especially the liver problems. So we acknowledge and we appreciate the fact that there will be something called middle molecule. And to middle molecule is based on, as you can see, the middle molecule is, which is over 50 kilodalton or above the weight, or some people just argue 30 kilodalton to 60 kilodalton or up to 80 kilodalton, somewhere around that line. So what happened to those particles? Because the urea, the urea model that we have been using for so many years, and the membranes that we have been using as a hemodialysis filter, They may or may not, actually. We don't have enough data, and it shows like very poor clearance of the middle molecule. And for the chronic patients, for the acute patients, more and more literatures are coming out that these molecules needs to be dealt with some better diligence, just because these middle molecules could be the determining factors of the outcome. And this particular case probably showing another thing, that all the markers that we have been showing here, like the bilirubin, the myoglobin, those are and these are all protein bound actually. So I mean the usual hemodialysis, unless we give it a very wide period of time, which is like the CRRT, they do not clear the protein bound molecules very well. So in that case, this kind of a hemoadsorption, which by the way is not very popular in America yet. I will shed lights on some other time on that actually, or why we have not been used to that. So those can be a real promise in our field. Actually, beta microglobulin is the one which we see as a real biomarker, which is a biomarker for the middle molecules, and we have shown over time that regular hemodialysis does not do a great job on clearing those. And I assume so is true for these bilirubins or the liver, other enzymes and all these myoglobulins. They may not be really cleared so well as a middle molecule as well. So in this particular case, as we see like the cytosorbs, or which is using the adsorptive method, they basically targets the middle molecules where the up to 80 kilodaltons, or the molecules like that, or the molecules which are protein bound, because of the natures of the physiology of the cytoabsorbs, can just attract and can filter some of it. And it's very important though to understand actually that this cytoabsorbs is not an independent device which has act on this patient. This patient, along with another filter, which is like the regular filters of the hemodialysis, this filter was used as a pre-filter to the hemodialysis machine. So the blood actually coming in there, get some toxins removed, and the blood actually going to the hemodialysis circuits before it's going to the patients. So there is two kind of filters that used here. And among these two kind of filters, as Dr. Ashraf Malik mentioned very nicely, actually, there are a couple of biomarkers. And in our case, actually, we would have followed the ammonia from day one, just because we know the patients with an acute liver failure, as of now, the only promising studies that it has shown, the high volume dialysis or the CRRT, which is a continuous replacement circuit, is the only promise that we have seen for the acute liver disease patients with the fulminant liver failure until they get a liver transplant or something like that. So in this case, actually, by default, these patients with a cytoabsorb, which is run for at least for 24 hours or 8 to 10 hours, is automatically change the patients in a CRRT mode as well. Just because, as you see, cytoabsorb does not do the blood flow more than 150 ml an hour, or max maybe up to 200 ml, which exactly is the CRRT blood flow. And these patients have been given very high volume dialysis as well. If I'm not mistaken, I have seen the dialysis flow in these patients was 2000 ml per minute, if I recall. Actually, in the regular hemodialysis patients, we do not even consider giving like more than 500 or 600 ml of dialysis flow. So in that particular case, by default, using the cytoabsorb, I guess, they were using a very high dialysis flow in this particular patients and was given a very prolonged treatment. That's actually, in my opinion, and I'm trying to be a devil's advocate here, actually, that these patients can be argued there are some confounding factors for the CRRT effect on this particular patients may have some leverage from the CRRT for the outcome. Can I prove it? Can I disprove it? No, I cannot. So that is the limitations of the the retrospective or the like the case studies and all this. Having said that, I looked into some of the literatures because I'm not so familiar with this device by myself. Uh, so the literatures up to 2023, there are quite a few meta-analyses for all the retrospective studies, a couple of small RCTs and all this. It did not show actually a great deal of mortality benefit. And these patients, it has shown like some of the ICU patients has gotten some benefits, some secondary outcome benefits and all this, but it's acknowledged that this can be a great tool. In this particular case, I have two comments. One is like, we are considering that these patients may have some herbal medicine that could be a potential reasons for these patients acute liver failure. So when the patient is getting like 2 days of dialysis, high intensity dialysis with some absorptions, it is maybe worth it to consider. Maybe the toxic materials has been dialyzed really well or cytoabsorbed really well, and the inciting factors for the toxicity has been removed, and this patient started recovering some. I'm not dismissing the idea of, or I'm not demeaning the idea of the like the great deal of sepsis in this case. However, we need to understand this patient was hemodynamically quite stable. This patient did not need any vasopressors as far as I can recall in the case, or there was no levophed or anything like that. And this patient, after just 24 hours, started recovering his urine output and put out almost like 3 liters of urine, if I remember right. So that itself was helping as well to remove some of the toxins from the system. Before I end, I just wanted to mention like ECMO is another one. Albumin-bound dialysis is another modality that we have been using in our system. Those also is targeting some of the middle molecules or the higher molecules. In this particular cases, had we been, if we had some baseline IL-2, IL-6 or TNF-alpha and post-treatment measurement, that would have been very helpful. I would recommend, or I would actually following this particular case along with the hepatology team, if they can make a case series on this kind of cases, a couple of cases like this, and that will be very publishable in anywhere in the world, in any high renowned journal. I'll leave it here, and then I'll try to touch base on a little bit later if we get a chance. Thank you so much.
Thank you. Thank you very much, Mahfouz. It's a really nice explanation. You made some very good point and excellent suggestions about this case and overall acute liver failure. And like you mentioned, ammonia level and using CRT in patients with ALF does help improve ammonia level because it's a continuous, you're dialyzing continuously because ammonia is something, because of the ALF, they have a high volume of distribution. So if you do intermittent one, you might not be able to kind of make it go or reduce the ammonia level quite effectively as compared to CRT. Before I go to Dr. Ehsan, I want to make a housekeeping thing, which I forget to mention. If anyone in the in this webinar, the participant has any question, please feel free put in the chat box, and we'll be happy to answer those questions. So if this is a very unique case study, and the treatment is something different, different than what we do on a day-to-day basis. So I'm sure there'll be a lot of questions that can come to their mind. So please feel free to put in the chat box. So I'll go to Dr. Ehsan to kind of give a comment of, I don't know if any other center in Bangladesh had used it or have been using this cytosorb in patient with ALF or even acute and chronic liver failure. Those are the two group of patients who, in a liver patient, we use it. So Dr. Karim?
Yes. Thank you, Dr. Ashraf Malik, for inviting me this session. I'm for the first time to attend this platform. I first thanks Dr. Ashik Maula and Professor Ghulam Azam for selecting such kind of important cases. I have some queries regarding that. What was the Is there any investigation done regarding the leptospirosis or leptospira antigen? And also there is I need some query about the platelet counts, because when I was working in the Medical College Hospital, now I'm working in the National Institute of Kidney and Urology, Dhaka, I encountered this kind of patients several times with multi-organ failure and also associated with acute pancreatitis. This type of patients. And we have, we have no facilities to cytoabsorb, we have performed intermittent hemodialysis, and strikingly, we see that this patient have recovered only 2 sessions of CRT or hemodialysis and associated with cytosol. But this kind of clinical scenario, what we have encountered, we need several sessions of hemodialysis, even 4 to 8 or 10. Then patient ultimately gets recovered. This is also very important because as Mahfouz says that bilirubin is albumin bound. So this and conventional hemodialysis, that is intermittent hemodialysis that we will do for renal failure, bilirubin is not decreasing in that ratios that of renal function improvement. So we need more and more hemodialysis, and clinical outcome is not so delayed and slow. And also, I also agree with some queries, that is, if the patient having ammonia level high, with the patient having developed hepatic encephalopathy. So this is a very good job for Bardem Center to do, because this type of multi-organ failure associated with liver failure, sepsis, and AKI, these cytobs are incorporated into the conventional hemodialysis or CRT is rapidly patient's outcome. I have some questions to the, what is the difference between MARS and CyTOR? Can you answer?
Yes, sir.
Yes.
Sir, I want to answer this question. MARS is the molecular absorption recirculating system. Here it is the albumin based dialysis process here, and cytosorb here is the albumin is not essential for the absorption. And in Mars, in cytosorb there is the absorption system are used, and it was mainly used for the cytokine storm, and in sepsis or liver failure or rhabdomyolysis in myoglobin. But in case Mars is it is very essential for it is only for liver failure. Sir.
Thank you, Ehsan, for your really valuable comment. Actually, we are lucky. We have a intensivist here, Dr. Habibur Rahman Lulu Bhai. He's also from Salimullah Medical College. He's, I think, I'm not sure, it's a 6th batch or 5th batch. Lulu Bhai, are you? I'm not sure. I think we need to get you access for you to talk. Let me. Is Biva here? Can you?
Yeah, can you hear me?
Oh, yeah, Lulu Bhai, thank you. Sorry.
Hi, Assalamu alaikum, everybody.
Good. We are lucky to have you. Lulu Bhai he's an intensivist. He's been working in the USA for a long time. He's graduated from Salimullah Medical College, and we're lucky to have him here. Unfortunately, I was not able to invite any intensivists because there are a lot of things happen in the recent weeks. But were you able to hear the case, or?
I joined a little bit late, but to the extent I heard, I just want to mention a case actually I heard in my last rotation in ICU just 3 weeks ago.
Okay.
And that patient is a heavy alcoholic, he came in with ethanol and ethylene glycol and methanol poisoning with severe acidosis, more than 20 lactate, and multi-organ failure, required multiple pressors. ALTSC rose to the level of 6,000-7,000 with all kinds of liver abnormalities. That patient, we provided CRRT on a daily basis. It looked like he's not going to make it, but fortunately, over the next 24 to 48 hours, he slowly stabilized and finally extubated him. Just to briefly share with you that that's an experience I just had recently. There was a fulminant liver failure. She initially started with CRRT and then changed to intermittent hemodialysis on a daily basis.
If you can make some comment, whatever you have, or if you have any questions, since you are not able to kind of hear the full case about acute liver failure, use of CRT or cytosorb. We in USA, like Mahfouz was mentioning, this is not a routine practice, still experimental. Any type of extracorporeal device is still kind of when we're doing it as a clinical trial. Most of our patients do receive CRT with, we do see some improvement of their ammonia and everything. But do you have any comment to make, Lulubhai, on this case, or anything with regards to fulminant hepatic failure? Management.
The comments made about the molecules and volume of distributions, size of the molecules, albumin bound or not, and the kind of technology that must be attached to dialysis machine or CRRT to get rid of them, certainly intuitively makes sense, logically makes sense, even though the data in some of those areas are not as rich. So it makes sense to me. But then depending on individual centers' availability, we also need to address the question of, in case we have limited resources, how do you get around that? But I think those points are extremely valid and relevant.
Thank you, Lulubhai. So lastly, I would like to go back to Professor Azam to kind of wrap up the presentation, and importantly, which Mahfouz mentioned, Atikbhai is also here, so I think we can hear from him first. Atikbhai, please go ahead before I kind of have.
Oh no, thank you. I think you and Mahfouz all said very well, especially the nitty-gritty of it, and thanks for Lulubhai to join at the end. Thank you so much, Lulubhai. I would not say much, but you can proceed. I'm just in and out. My son is moving to his dorm, so I'm just helping him out a little bit today. So, but please continue.
Sure. So lastly, before I go back to Professor Azam, like Mahfouz is mentioning, I think it'll be a good idea since you have the cytosorb machine. And also, Professor Azam, if you can let us know if any other hospital or center in Bangladesh have this machine or any other extracorporeal device, publish it as a case series or case report. I mean, it's going to be hard to do as a randomized control trial in Bangladesh setting, but at least series of cases, with kind of truly get all the detailed data, different levels, so that kind of we have some idea, because in USA that it's not routinely practiced, and clinical trial, not many centers are doing it. Most of the data we actually get from Europe or Asia actually on these kind of devices, and some centers in Europe actually they use it really more aggressively than us. So if you can have this as a case report in the future, I'd like to hear from you and from your center, as well as if any other hospital have it, then we can. So that something will be really helpful as far as in our clinical practice. Professor Azam, please, if you can.
Please.
Ashraf Bhai, can I just interject just for 1 second before it goes to Professor Azam? Yeah.
Yes.
Professor Azam, while you, wrapping up and shed lights on this, would you please mention a little bit about the cost of this as well? Like how much is costly it is in comparison to...
Somebody has the same question, but he can all have him answer this question.
Okay,
Yes.
perfect.
Okay. Thank you, Professor Malik, for again, I must be grateful, and our department is much honored by giving a chance to present our case. And I think Professor Shahinul Alam, VC of BMU, is connected with us. Shahin bhai, jodi কোনো একটু যদি একটু মন্তব্য করেন আমার wrap up করার আগে।
আচ্ছা
Shine bhai,
Shine
can you? Although he's in now in UK, he's for university purpose. He's visiting an University of Oxford. Shine bhai, আপনি কিছু বলবেন? শুনতে পাচ্ছেন?
Shine bhai?
আচ্ছা, okay.
Okay, ঠিক আছে।
হ্যাঁ, Shine bhai, না Shine bhai, মানে unmute করুন।
Wanted
Yes,
to
I'm hearing the case. Really, it's an excellent case, but I think there is what it has been mentioned by Dr. Mahfouz probably. I think it's a wonderful result in this case, but we could not conclude that the only cytosol is the contributing for the positive factor, positive results. I think it should be further evaluated. And one thing more is that it's expensive, though it is available in our country. Only these are my comment.
শাহিন ভাই, আশরাফ, আপনি তো বিজি থাকেন, সো আমি আপনাকে ইয়েকে বলছিলাম, এলিনকে, সো আই ডোন্ট নো এলিনের সাথে আপনার কথা হয়েছে কিনা, বাট আমি জানি আপনি খুব বিজি।
Actually, every time, usually I try to attend this program, but almost every time I fail.
না, ইটস ওকে, অ্যাট লিস্ট আপনি অ্যাটেন্ড করতে পারছেন, এটা আমাদের জন্য খুবই ইসের বিষয়। তো এই BMA থেকে do we have cytosorb and any other extracorporeal device?
We don't have the extracorporeal device, but during the dialysis we can use this the cytosorb.
Acha, it's good to know. Okay, thank you.
So it's my part if we are coming to that closer to the meeting, I think. Malik bhai, okay?
Yes, yeah. If you have anything to add, Professor Azam, about the case or what's your future plan about
some question analysis. Dr. Ehsan Karim asked about the leptospirosis testing. We did it, and it was negative. And platelet counts are all the times was normal, within normal range. And hepatic encephalopathy, actually, it was not an advanced grade of hepatic encephalopathy. The patient is just somnolent and recovered immediate after dialysis and all other parameters. This is my response to Ehsan Karim. And finally, I should inform about the costing. It's a cost for country like us. It's 1,26,000 per setting. So it needs a huge costing.
I'm sorry,
1,26,000 টাকা per setting.
Per session.
তো এটা একটা বড় তবে আমি বলি যে এটা বাংলাদেশে it has been used in other institutes. Actually, this device or technology was brought to us by Radiant Pharmaceuticals, and it has been used in so many other centers like the private settings, Evercare, Square, Anwar Khan Modern Hospital, Asghar Ali Hospital during the COVID period, because its name is cytosorb. Cytokine storm due to any reason. In the COVID period, some of the intensive care unit departments of the said private settings or the capable people of some wealthy state, they got admitted and they got treatment during the COVID period. So it was actually came to Bangladesh during COVID period, as I have been informed from the Radiant. And finally, I asked them whether you have collated the data, because it's I asked them how many patients. They told me that it's more than 20 patients. If they could collate all the data, then we can get a better information because of the cytokine storm-like situations like COVID. And actually in liver condition, so far my knowledge, we put it at Bardem Hospital first time, and just 2 weeks back, I have another center where I do my private practice in Bangladeshi style, Anwar Khan Modern Hospital. One of the renowned nephrologists, he referred me a boy of 18 years, and the boy developed acute liver failure, although the etiology not explored, and the patient was put in this cytosorb, and there is a success story. So in the future, I will collect the data, especially on my liver disease, and I will make a publication on this device or on this technology. And in the new era of liver transplantation, what is going to be some question should come here, that whether it is indicated during SCLF, acute on chronic liver failure. So I have searched for that, and I found that in SCLF, acute on because I have some residents are joining here my students and also from other. For the residents or the junior doctors, I like to mention here that actually this technology is actually applied for acute condition, not in chronic liver disease and not in cirrhotic decompensation. But in ACLF, there are some indications, and there are some case reports are coming that in case of ACLF, if we put this technology, then there are some good outcomes. But yet to wait for days, months, coming days, so we can collect some data. But actually, our time is running short. Liver transplant era, we are running in this. The patient who are waiting for liver transplantation. Actually, liver transplantation is end-stage organ disease. Already there is parenchymal damage and the organ is not functioning. So this cytosorb or the dialysis techniques or the hemoadsorption, MARS and others, these are the bridge to transplant maybe. But SLF, this is also a bridge to transplant. And all the SLF patients may not need liver transplantation. There are some criteria because in SCLF, if we could remove the acute insults, especially infections, then the patient will recover. So in every SCLF patients do not need liver transplantation, but we could treat the acute conditions like sepsis and other infection that complicated pneumonia, AKI, and other sepsis-related complications. In that case, possibly there may be a role, but I just put a speculation or my hypothesis that SCLF conditions, whether we should use or not, it depends on the costing of the patients as well as the patient's age, other comorbidities, and hope that the patient will get a benefit by this huge cost from a country like Bangladesh. So I like to conclude again, giving thanks to the organizers, PHA, Atik Bhai, আমাদের স্পেশালি আমাদের ভিসি মহোদয় আমাদের সাথে অ্যাটেন্ড করতে পেরেছেন। আমি ওনার বক্তব্য শুনলাম এবং আমরা গ্রেটফুল। ফাইনালি আমাদেরকে আবারও সুযোগ দেবেন, আশা করি ইন্টারেস্টিং কেস আমরা আবারও ভবিষ্যতে প্রেজেন্ট করতে পারবো। থ্যাংক ইউ ভেরি মাচ, গুড নাইট এভরিবডি।
Thank you, Professor Azam. This very interesting and case, and it's really something, and it's a learning process, a learning curve. So as you're gonna use more, we would like to hear from you in the future, and we hope that like BMU, I know we've been talking with Shaheen Bhai a lot about the liver transplant program in BMU, and hopefully something we would like to see in Bangladesh, start a like ongoing transplant. So this is, I've been always talking with Atik Bhai's সাথে আমি সবসময় কথা বলি যে liver transplant is something, it's my passion. এবং আমি বাংলাদেশ থেকে যেহেতু পাশ করে আসছি, আমার একটা ড্রিম যে বাংলাদেশে একটা liver transplant program ongoing, not like something 1 or 2 transplant and then stop it, something we had it in the past. So এবং শাহিন ভাই হচ্ছে, আমি শাহিন ভাইয়ের প্রতি গ্রেটফুল যে he has the same vision as mine, এবং শাহিন ভাই খুবই এটাতে he's putting a lot of effort এবং অনেক কিছু করতে চাচ্ছে। So and as if PH এর পক্ষ থেকে আমরা শাহিন ভাইকে যতদূর পারবো এখান থেকে হেল্প করার in any way with the education, transfer of technology, whatever needs to be done. এবং Professor Azam, I know you have interest and you wanted to start, so this is something we are happy to collaborate with you from PHA anytime when you plan to start. So with that, I think we're almost done. If nobody has any questions, anything, we'd like to finish. And again, thank you, Professor Azam, the presenter, and all the moderator. Thank you, Lulu Bhai, last minute join, and then and again thank you, Shaheen Bhai, also joining us as well.
Thank you. Good to see you.
Thank you, everyone.
Malik Bhai, আপনার
আসসালামু আলাইকুম স্যার।
আপনার মেয়ের বার্থডে উপলক্ষে হ্যাপি বার্থডে টু ইওর ডটার।
Happy sweet 16. Happy sweet 16.